And welcome. My name is Ryan Tappy and I work with the ALS Association. Thank you for joining us for this installment of Empowering Your ALS Journey, a webinar series. The goal of this series is to empower you to live fully and with purpose regardless of where you are on your ALS journey. The title of today's webinar is Supporting Children When a Loved One Has ALS. There are a few things we want you to know before we begin. First off, please know that you are muted and not on camera so you can relax and enjoy the presentation. There will be time at the end of this webinar to answer questions. You should see a chat box feature on your screen as well as a Q&A feature. You can use either of those options to submit questions you may have. All messages submitted will only be viewable by the host and panelist. We will review and answer these questions with our speaker at the end of the webinar. Please keep in mind that our speakers today cannot provide opinions or advice on your personal experiences, and questions should be more general in nature. As I was saying, we do have a very short survey. We are asking that everyone complete after the webinar. The survey will appear in your browser once the webinar ends. The survey helps us to know your thoughts on this presentation and topics you would like us to consider in the future. This webinar is recorded and will be available on our website and the educational webinars page within about a week. Lastly, please be aware that while this webinar will primarily focus on supporting children through a loved one's ALS journey, it will also include some discussion of sensitive topics, such as helping children prepare for a potential loss. We are so fortunate to be joined today by two amazing speakers who will lead us through the topic. The first speaker I'm going to introduce is Dr. Allison White. Dr. White is a clinical psychologist with the Daniela Lipper ALS Parenting at a Challenging Time program, also known as PACT, in the Healy Center for ALS at Massachusetts General Hospital. She's also a clinical psychologist with the Marjorie E. Korf PACT program in the Massachusetts General Hospital Cancer Center. She is an associate director of child and adolescent dialectical behavior therapy program at MGH and an instructor in psychology at Harvard Medical School. In addition to providing guidance to parents facing serious medical illnesses, Dr. White provides psychotherapy to children, adolescents, families, and couples as well as guidance to parents whose children are facing substance use and mental health challenges. She also enjoys teaching and supervising psychology trainees. Presenting alongside Dr. White today is Dr. Cindy Moore. Dr. Moore is a clinical psychologist who leads the Daniela Lipper ALS PACT program and directs the Marjorie E. Korf PACT program in the MGH Cancer Center. She occupies the Timothy Christopher Davidson Endowed Chair in Psychiatry at MGH and is an assistant professor of psychology at Harvard Medical School. Throughout her career, she has provided parenting guidance to adults with life-threatening illnesses. In addition, she provides psychotherapy to bereaved adults with a special interest in prolonged grief. She teaches locally and nationally about how parents and healthcare professionals can support children living with a chronically ill parent. She conducts research on challenges faced by parents who are managing serious medical illness and supervises psychology trainees. Dr. Moore and Dr. White, it's great to have you joining us today, and I'm going to now hand it off to you to present.
Thank you so much, Ryan. So neither Allison or I have any financial disclosures to share with you. And we would also like to welcome you all to this webinar and to thank Ryan for inviting us today. I probably don't need to tell any of you that one of the most difficult parts of living with a serious medical illness is seeing its impact on children in the family. And we're hoping that this webinar will give you some ideas about how to support the children in your lives so that any negative impacts of ALS on children can really be minimized. One of the most important ways to support children is by talking with them and listening to them. So we'll be spending a good amount of time discussing communication about hard things, including anticipatory grief. And we'll also describe some online resources that we hope you might find helpful. We hope to model for you what we'll encourage you to model for your children, being open and honest about difficult topics and trying to find ways to move through them together. We hope to be able to talk about some of the challenges that many of you may be facing in a way that feels manageable to all of you. But I want to acknowledge that some of this might be difficult to think about. So as Ryan mentioned, the webinar is being recorded, will be available on the ALS Association's website. So please do what makes sense in terms of choosing the right time to dive into this material for you. I wanted to share just a little bit more about our professional backgrounds. The Parenting at a Challenging Time, or PACT program, was started at Mass General in the Cancer Center by a child psychiatrist named Dr. Paula Rausch about 26 years ago. 6 years ago, we created a sister program in the hospital's Healy Center for ALS, and we're very fortunate to have received philanthropic funding from the EGL Foundation in honor of Daniela Lipper, and are very grateful for their ongoing generous support. So, as Ryan shared, Allison and I are clinicians in both the Cancer Center and the ALS PAC teams. The mission of both of the PAC programs is to address the parenting and grandparenting concerns of medically ill adults. We partner with parents to support children's emotional health and resilient adjustment to a loved one's illness. And we take care to be sensitive to differences among families in language, culture, and then family member roles. What we offer are psychoeducational consultations to parents and grandparents of infants through young adults who are treated in the ALS clinic at Mass General. And we will describe our approach as trying to serve as thought partners to parents. So, as child psychologists, we're familiar with development across the lifespan and the impact of medical illness on families, but we appreciate that parents know their own children best. The principles that we share are supported by an evidence base and focus broadly on the importance of finding ways to communicate as about even painful topics, and also the value of parental attunement to children's emotional lives. A quick note, it's always a little challenging to find the best word to describe all the adults who might be caring for and communicating with children, caregivers, parental adults, parents and grandparents. So we're just going to say parents throughout this presentation, but we're really including other caregiving adults in that description. So you're meeting two of the PAC team clinicians, Allison and I, today. Dr. Christine Wu is our third and newest PAC team member, and just wanted you to be introduced to the whole team. I want to start by naming some of the challenges that a serious medical illness can create for adults, specifically in their roles as parents. These have been identified by research on parenting with ALS, and then also other illnesses like cancer, Parkinson's, or MS, and certainly also come up in our own clinical experience. Most parents with ALS have changes in energy levels, mobility, and mood, and sometimes cognitive changes as well. And all of these, of course, can affect interactions with children. So a parent's engagement, enthusiasm, and just kind of interest in the child's life, and then certainly ability to participate in activities with children. Some studies have suggested that medically ill adults who have dependent children at home seem to be more vulnerable to depression and anxiety than non-parents are. All of this means that there may be parts of the parent's role in the family that have to be forfeited. For example, as the family chauffeur when driving is no longer possible. And even though most parents complain at some point about how much time they have to spend in the car driving children around to school and activities, many really also appreciate how children might be a little more talkative on car rides, or they like being able to hear their child talking with friends about things that they might not share directly with adults. So parents worry about someone else stepping into certain roles, or just about there not being anyone else to step in. We also know that parents who are coping with a medical challenge believe they have less efficacy as a parent. So, in other words, they're not as confident about their ability to raise and influence their children in a healthy way. They also feel less satisfaction in their roles as mothers and fathers. So, given how important the parenting and grandparenting role is to so many adults, I can't help but think that losing confidence as a parent could be part of medically ill parents' risk for depression. And finally, guilt is very common. It's probably true that most parents feel some level of guilt about parenting fails just at baseline, but parents with ALS are extra vulnerable for needing care or needing help from children, for not being able to do all the things they used to do or be the parent that they quite want to be. So each family and parent, of course, has individual concerns, but there are a number that are shared by many parents. One of the most common is how to talk with children about their illness in an age-appropriate way. It's particularly difficult to know how to talk about a diagnosis that has a challenging prognosis, and also to talk about things getting worse rather than better. Parents, of course, worry a lot about not being around to see children grow up and about how to prepare children for a loss. Some parents are interested in and kind of open to thinking about what kind of legacy they can leave, like what mementos of love their children might value. Parents also worry about how children will adjust to changes in the parent and to the family routines. They worry about children's moods and behavior, performance at school, sometimes extracurricular activities that are important, and then deciding whether or not to seek professional support for a child with a therapist or counselor is another common concern. We hope to address most of these in the talk today. So, what is it like for children living with a parent with ALS? Most children do take on new responsibilities when a parent is ill. So, things like household chores, watching younger siblings, and often providing hands on care for a patient or for a parent, excuse me. Some children provide care for many hours a week, and Melinda Kavanaugh has done research really suggesting that this is that young caregivers are kind of an overlooked population. And new roles come with both rewards and costs. Children may take quite a bit of pride in new skills, feel really good about being able to be helpful, feel closer to the parent in some ways, and also find that actively doing something helps them feel better about a situation that's largely out of their control. Um, but if there's limited support for the child or expectations are really too high or not developmentally appropriate, children can also feel pretty stressed or kind of resentful. They can miss opportunities for other activities that are important for their development, like time with friends or time doing extracurriculars. And one study of adolescent caregivers found that they have poorer sleep than peers, and were more likely to use sleep medications. So there can also be consequences for the child's own health. It's clear that children cope with a whole range of emotions that might include worry, sadness, anger, a sense of injustice or unfairness, feeling actively concerned for a co-parent, kind of embarrassed, but then also empathy for a parent suffering, or with younger children, maybe even excitement about any special attention that the family's receiving. It's important to know that most children do not develop serious mental health problems in response to a parent's illness. So in other words, they don't usually meet criteria for a diagnosis like major depression or an anxiety disorder. But a number of children will experience emotional distress, and it can go on. Feelings of anxiety and sadness that don't quite rise to the level of a clinical diagnosis, but are nonetheless important to pay attention to. Children may experience intrusive thoughts, worries about the parent, or worries about themselves. Somatic symptoms are not uncommon, like headaches and stomach aches, especially in school age children. Behavior changes such as social withdrawal or declines in academic performance can occur. Some children experience lower self-esteem, and some experience relationship difficulties. So, for example, feeling kind of disconnected from peers who just may really not understand their experience at all. I read a study recently about the kinds of supports, professional and not professional and more general, that teens would like and what their parents would like for them. I was struck by how each family and adolescent really is unique, that there wasn't clear agreement about what kind of support is universally best or needed. So, for example, some teens really wanted to be able to go to a parent's medical appointments, others had no interest in that. Some preferred that parents would do all the communicating about ALS, and others wanted to be able to hear things directly from doctors. Some wanted school to be extra understanding of their circumstances, and others were clear that they wanted to be treated just like their peers. And so it really highlighted the idea that there is no one size fits all support. Um, Along those lines, sometimes it's not really obvious whether a child needs specialized mental health support or not. And not every child does, but some will. And some of the things we encourage parents to watch for include changes in a child's mood, behavior, or functioning that persist for more than a couple of weeks, and are noticeable in more than one setting. So, for example, at home and at school, or with siblings and with friends. If a child had been diagnosed or treated in the past for a mental health condition, and it seems to be either coming back, recurring, or getting worse, then it's a good idea to seek additional care, often with a provider that a family's worked with before. If a child asks to see a therapist or counselor, it's important to take that seriously. And any child who's engaging in risky behaviors, that's a sign that they do need additional support. Any child who expresses any thoughts of hurting themselves or ending their lives really needs an immediate evaluation or a very urgent evaluation, often either with a pediatrician or a hospital emergency room. I have to acknowledge how difficult it is to find mental health care. I wish we had a list of child therapists who are familiar with ALS. Unfortunately, we don't. I usually will recommend looking for referrals. It's in several places at once. So it could be with your pediatrician. Some just have a list of providers who are kind of local that they know about. And some pediatricians' offices actually have a social worker, or counselor working directly in their office. Um, it's good to see what kind of counseling is offered at school, or if the counselor there can recommend someone in the community. For safety concerns, the nearest hospital emergency department might be the only and best option. Sometimes looking at your insurance company's website can provide a list of approved providers for your insurance. And then you can use another database, like Psychology Today Find a Therapist is one, to learn a little bit more about that person. So with the Find a Therapist database, it's a national database. You can search with a variety of filters, like gender of therapist, zip code, areas of interest or expertise. And then you narrow it down, you'll see a photo of the provider, and they give a little bit of a blurb about how they work. And another sort of similar database is for social workers who are trained as therapists, and that one is therapymatcher.org. I also just want to highlight two written resources on the Mass General ALS Pact program's website. So one is shown here on the right. It's called Seeking Mental Health Support for Your Child. So it includes a number of questions that you might think about asking a prospective therapist prior to making an appointment for your child. The other is a guide to ALS for mental health clinicians, which might be helpful to share with a therapist who has experience with children and maybe with other medical illnesses, but maybe isn't so familiar with ALS specifically. We're going to share the website address at the end, along with some other resources, but you can always search for MGH ALS Pact, and you'll find the page easily, and then those resources towards the bottom. We want to spend the rest of the time focusing on some of the many things that you can do to help make things go well for your children. So a good amount of research has shown that there are elements of family and community environments that are almost universally beneficial to children that can help promote resilient adaptation to a whole variety of stressors, including parental illness. The Harvard Center on the Developing Child created this illustration of resilience that I've adapted with the additions of the gray and green boxes. So the idea is that protective experiences and coping skills on one side counterbalance significant adversity on the other. So resilience means that even when there's a heavy load of risk factors stacked on the negative outcome side, a child's health and development still can tip toward positive outcomes. The gray box above the left-hand side of the scale shows that one of the risk factors for children is a parent's depression or anxiety, and that can be either a parent with a medical illness or a co-parent. So one point we'd like to make strongly is that caring for your own emotional well-being as a parent or grandparent is not selfish, because your children will benefit directly from your being as emotionally healthy as possible. The most important factor that's come up in research for developing resilience in children is having at least one stable and committed relationship with a supportive parent or other caregiver. The green box above the right-hand side of the scale shows some of the specific elements of those relationships that are keys to tipping the scale toward positive outcomes for children. So the first factor is warmth, not a huge surprise, but affection and support from parents. We want to make sure that children feel loved, that their needs matter. So physical affection, loving words, regular one-on-one time, showing up in different ways to cheer them on, just finding ways to make sure that they know someone's on their side. All of these help create a warm relationship. Cohesion, the next factor, means a sense of family togetherness, that feeling that your family is part of the same team, at least a lot of the time. Illness can make it really hard for families to have fun in the same ways as before, and as a result, maybe not feel quite as close to each other. So families can try to feel more cohesive by looking for new ways to enjoy time together, and also by protecting family time that's not always focused on the medical illness. So sometimes adding new elements to maybe quieter activities can work well. So, for example, you're watching a regular TV show together, but adding special snacks or drinks to create a little bit more of a ritual or special occasion feel, or playing a quiet game, but under a blanket fort. The next factor, control, relates to a child's feeling that they're kind of captain of their own ship. That's why it's a ship's wheel. So this can be supported by sharing information about the ALS, and that's a really important way to give a child a sense of control, and how the child's life may be affected. We're going to talk a lot more about that later, so we'll come back to that piece. Um, Giving choices, though, can also increase a child's sense of control. So, for example, taking children's preferences into account when possible, in decisions that are going to affect them. So, for example, what chores are the least annoying to take on? They may not have a choice of having to help out more, but they can have some say in what exactly they're doing and when. Having regular routines at meals, bedtime, after school also increase children's sense of control and predictability. Also, reminding children about coping strategies that have served them well in the past can help a child feel more in control of a challenging situation. So, for example, a mom I worked with was had a conversation with her son about how his math grades had improved after he started going for extra help. And they talked about how his willingness, after some some pushback, to receive help and accept support was really a strength for him, and a good coping skill. And then next, connections. Parents can try to build connections with adults that they know and trust outside the immediate family for children to talk with. So it can be people who know the parent really well, others who just really get the child. And this is modeling for children that it's not disloyal to attach to other people, as well as creating new opportunities for conversations and support from other people. It's also worth thinking about a child's connections at school, like, kind of specifically, and identifying there a point person who can maybe provide extra support there. It might be a teacher, could be a coach or a counselor. And then you'd hope that that adult would also provide updates to parents about how a child's doing at school. And then last, but definitely not least, open communication supports children's positive adjustment. So a lot of parents tell us that it's really tough to find the right balance between sharing too much and too little information with children. And it's probably easiest to share too little for a number of reasons. Understandably, parents don't want to distress or burden children. Sometimes parents worry about throwing off a child's academic progress or social or emotional progress. Some parents worry that maybe an older child won't launch as they'd hoped, like maybe won't attend college as planned or accept a job opportunity, especially if it's at a distance from home. Some communication blocks are more an issue of timing. So sometimes parents may just want to delay a conversation until like after a high school or college student gets through exams or prom, until after some special event or holiday, or until some other stressor has resolved. And sometimes that's fine, and sometimes it's not so feasible, and so you have to sort of think about that. Sometimes parents are again understandably concerned about their own privacy, and this maybe is true, especially with younger kids. So they realize that once their child knows about a diagnosis, the child could share information with more people than the parent would wish. But then they're also reluctant to tell the child that they have to keep a secret. And many parents are really frightened about being asked about whether they could die and knowing how to respond to that very, very tough question. So it is very easy to come up with reasons to avoid talking about ALS with children, but there are some real downsides to this kind of avoidance. Children are observant and often very perceptive, especially when it comes to things that can threaten their security. And this makes it really hard to completely cover up changes. Even in very early stages of an illness, children can overhear conversations with other family members or sometimes with a doctor. They notice even subtle physical symptoms, or they can sense the emotional climate, that adults are worried or sad or just kind of more impatient than usual. If no one is talking about those confusing changes, then children will likely create their own explanations. The problem is that those will usually be incorrect or at least incomplete and can leave kids feeling anxious and unsettled, but without really a clear way to ask questions or talk about things. They may not have the language to kind of put their fears into words and follow up on it with parents. So it's true that one way to protect children is by shielding them from information that will be upsetting. And that is definitely appropriate in a number of situations, but not in every situation. So a different way to think about protecting children is by preparing them for changes, by giving them a roadmap for what's ahead, and to be a partner with the child in coming up with ways to cope with the challenge. So sort of a bubble wrap versus a map approach. So honest conversations help children make sense of their perceptions, what they're noticing, and their experiences. And that helps them adjust to what's happening and allows them to feel understood and also included. Open communication can create space for parents to really hear and address children's worries, ease confusion, and then also plan together for changes that are expected. And that's good modeling of what we would call approach-based coping, which tends to be helpful. Um, and also, many parents have already talked with children about how much they value honesty in the family, even when it's hard. We want our children to come to us when they're struggling or hurting, and when they've made mistakes, and they know that we'll be scared for them or even mad at them. Teenagers especially need to know that parents can tolerate hearing about their challenges and mistakes. So talking honestly about illness is an opportunity to show and not just tell kids that talking about hard things is valuable and also doable.
Thanks, Cindy. So I am going to take over for now and do a really deep dive into communication to start with. And so Cindy did a really nice job about talking about why we believe in talking openly with children. And again, now I'm going to really think about how to do that. So, first, some general guidelines. The overall goal of open communication is to develop a shared family narrative, to explain changes, to plan for future changes, increase connection and family cohesion, and reduce uncertainty and confusion. Our team uses a general outline to help parents get started with sharing a new diagnosis or providing an update about treatment. So I'll get into more specific scripts later, but here are some of our general principles. So parents can start by reviewing what children already know about the situation. For instance, that the parent has visited the doctor several times or they just had some tests. Parents might also ask if there are other things that children have noticed or wondered about, or if they have any ideas about what's happening. Children often, as Cindy said, are very observant and can put things together in pretty surprising ways. For a new diagnosis, the next step would be to name and describe the illness in plain, simple language. And if it's later in the treatment, the goal would be to share updates about changes in a parent's medical status. If there are noticeable changes in a parent's functioning that relate to disease progression, we believe it's really important to connect those things explicitly. Next, a parent can describe the care plan in simple terms and whether that plan is going to have any impact on the children. So, for instance, I'll be starting B12 injections to help with my ALS, or I'm going to be traveling out of state every 6 weeks for a clinical trial. Then, parents should check the child's understanding of the information and also spend some time talking about and normalizing each person's emotions. It understandably tends to be easier for parents to talk about facts and plans, and sometimes they feel really relieved if children don't bring up any emotions, but we don't want children to feel like they shouldn't share how they're feeling. And then later in the day, after this initial conversation or in the next few days, it would be ideal if an adult could follow up with each child again to check in about understanding and emotions. It's probably smart to pick a time that the child is at their most open. Sometimes that's bedtime or on a car ride. And we also recommend parents tell their children, don't worry alone. As time goes on, you can also ask your children as you share updates, am I sharing too much information, too little, just the right amount of information? You can continue to check in to see if they have any questions. It's also helpful to note with questions, it's really helpful to think about whether there is a question behind the question. So, for instance, if your child asks, will your big wheelchair arrive in July? This may be a genuine question about when the wheelchair will arrive, but maybe it's because your family had a family vacation in July and the child is wondering if you're still going to go on it. Remember, related to questions also, that questions and concerns are often egocentric, i.e., about the child, developmentally appropriate and normal, and they're often very concrete. Finally, as a general principle, we believe it's helpful to express confidence in your child and your family's ability to cope with ALS and the challenges that come with it. Next slide. So, getting into a more kind of detailed understanding here. So, if you want to have a conversation with your child about your diagnosis, here are some ways to start the conversation, acknowledging that starting these conversations can feel awkward. So, again, one way to start is to ask your children what they've noticed about you, your partner, their grandparent, etc. Or if they've already mentioned a change, you can follow up and find out if they've noticed other things too. You can then summarize and validate their observations. That could sound like, yep, you've noticed that I've had a few falls, I got some scrapes and bruises, or that dad has been coughing at meals and last night he almost choked. You may have noticed that grandma is getting out of breath easily. Next slide. I'm going to go over some scripts specifically in the next slide, but before I do that, I want to give a few more pointers about describing ALS and having these conversations. So generally, it's helpful to be concrete. So ALS affects this part of the body. At the same time, analogies can also be really helpful. So in this case, one might say that the brain talks to the muscles, kind of like how electrical wires throughout a house carry signals from the switch to the light. When someone has ALS, it's kind of like the electrical wires don't work as well and signals get weaker over time. This means that the parent's muscles will get weaker over time. For younger children, especially, but everybody as well, it's important to remind them that ALS is not contagious and nothing that the parent, grandparent, or the child did caused ALS. We also want to acknowledge how difficult it can be to tell a child that you or a loved one has ALS. We talk to so many parents who are understandably hesitant to disclose their diagnosis. And I think that there are pros and cons to consider with that. We often think about naming ALS now versus later. And so I'll offer kind of a few considerations for you to think about this. One is if you don't feel comfortable naming ALS immediately, consider calling it something else. Maybe it's motor neuron disease, a condition, a disease. Basically, it's helpful for children to have some sort of schema or framework by which they can connect the functional changes that they're observing to something. So, mom uses a wheelchair because of her motor neuron disease. Also, note that children, especially younger children, don't typically have the same association to the concept of ALS that adults do. So you might want to protect them by not sharing this information with them, but note that they might not be kind of bothered by it in the same way that you are, at least initially. And also, we will say that we believe in the thoughtful timing of disclosure. So even if you don't share ALS now, you can do it later. Sometimes people choose not to say it now, and then it becomes kind of inevitable over time. There's sort of a natural speaking point about it. We also can understand and talk to parents of older children who want to delay the use of ALS, given how much their children can read about online. I'll talk a little bit more about that in a future slide. It's also helpful to consider how many people know about you or your loved one's diagnosis. Are you or your loved ones going to be talking about ALS? Will a child hear about it that way? Generally, we want children to hear information from a parent or a grandparent directly rather than overhear information. Regardless of what you initially call it, you can have what we call stepping stones conversations over time. You might start by naming it. At the next juncture, you might explain that ALS isn't going to get better, as kids often might ask, when is dad's leg going to feel better? You then might explain that ALS will actually get worse, and then explain also how it will get worse. At the next stepping stone, you could explain that ALS will limit one's lifespan. But of course, know that families really do this communication differently, and there is not a right or wrong way to do this. Parents sometimes acknowledge that there's no cure right at the beginning, often depending on the age of the child. But for younger children, especially who don't always have the best sense of time yet, it can be helpful to stay a bit more in the present. Next slide. So we have some scripts. As you recall, we start with naming what the child knows or has observed. Listed on this slide are possible scripts to use. And so we want you to pay attention to a couple of things. One, we like to be concrete. We like to generally focus on what the child can observe. We outlined some different ages here, but please know that it's not set in stone. Children have different language skills, so you can really decide what would be most appropriate for your child. And for ages 5 and above, again, not a strict cutoff, you'll see that we've added a sentence at the end about how ALS can't be cured. So for younger children, you might say, that dad has been walking more slowly. That's because the muscles in dad's leg are weak because of something called ALS. Dad's using a cane to help him walk. A little bit older, that dad has been walking more slowly. That's because dad has something called ALS or motor neuron disease. You might know that our brains are in charge of making our bodies move. ALS makes it hard for dad's brain to talk to the muscles in other parts of his body and makes his muscles weaker. That's why dad needs a cane to help him walk. You might clarify later or immediately. Resting might help dad's walking, but it won't make ALS go away. For 8 and above, very similar to everything before, but you might add a little bit more education about motor neurons. So you might say ALS causes problems in motor neurons. Motor neurons connect our brain to muscles all throughout our body and send messages to those muscles. Well, without these messages, dad's muscles don't always do what he wants them to do, and they will get weaker over time. Again, to clarify how it works, dad takes medicine to try to stop his muscles from getting weaker, but we're not expecting that dad will walk the way he did before. Next slide, thanks. We also want to offer a few pointers for involving and communicating with adolescent children. So, in terms of communication, note that adolescents often look up ALS on the internet, like many of us do. You can ask then when you communicate with them, what have they read or heard about ALS? Or some parents are able to give instructions about mindful internet use in advance. So you might say, be mindful of what you read on the internet and come to me with questions. You want to clarify what applies to your health specifically with a reminder that your medical team knows your ALS the best. And you can also remind them that ALS often looks very different across people. Even if you think your adolescent understands the facts about ALS, they often will still need a place to process their emotions, ask questions, etc. And even as communication gets more sophisticated with this age group, analogies like electrical wires, like I said before, those can still be really helpful. You may have also experienced that adolescents and young adults, especially, sometimes attend doctor's appointments. This can feel helpful because questions can be clarified, interventions can bring a sense of relief, but appointments can also feel sad or worrying. So, if possible, talk to your care team in advance to let them know that you wish to bring your child to the appointment, and so that you, your co parent, whoever else is involved in the care team, can plan for how the visit might be structured and what might and might not be discussed. It can also be helpful to preview with the adolescent what the visit might look like, and then, if and then process the experience afterward. Next slide. We also believe that it's really helpful to communicate about upcoming changes or procedures with children. So, we are going to give one example about getting a G tube. And we encourage you to think about these 5 W's as you talk to your child about this change or this procedure. So, you'll want to explain what a G tube is and why the person needs one. So, mom is going to get something called a G tube. She will have a tube connected to her stomach, and we will be able to connect a special bag to the other end of the tube. The bag holds a liquid that has all of the energy and vitamins mom needs. The liquid will go through the tube right into mom's stomach. Why? ALS is making mom's chewing and swallowing muscles weaker. She gets tired from chewing, and she can't swallow food safely anymore. The G tube will prevent her from choking on food and make it easier for her to get all the energy and vitamins her body needs. It can also be helpful to explain where and when the procedure will take place. The G tube is put into mom's stomach by a doctor. She'll go to the hospital on Friday to get the tube placed, and we expect that she'll be home the same night. Our understanding is that sometimes patients stay overnight in the hospital. Often it's a day procedure. But basically, based on guidance from the medical team, you might explain how long a parent is expected to be there and leave some room for change and flexibility. If you then later expect to have home care nurses, you can foreshadow that a team of helpers or nurses will come to the home for the next few days to help us learn how to use the tube. We also often see common worries in children, such as about pain and changes in family traditions. So, for pain, you might say doctors give special medicine or anesthesia before putting in the tube. And then, in terms of family traditions, you can have honest conversations about holidays and rituals and you can talk about what will and won't change. A few other notes about this one in particular is that family members, especially older children, may need to learn how to care for the tube and skin around it to keep it clean. So alert children that they may need to learn how feeds are given through the tube or any other instructions related to daily activities or what to do if the tube falls out or if any other problems occur. It can also be helpful to acknowledge that this can feel like a lot of new information at the beginning, and everybody needs time to figure this out. You might say, "We will do this together, and with practice, it will get easier." Remind children also that they should feel that they can say something or ask anything if anything is unclear. Next slide. So now we want to talk about communication, specifically answering questions about death. And we want to acknowledge, of course, how difficult and also how important it can be to answer questions about death. Worrying about how to answer a child who asks if a parent could die is really stressful. And of course, there is not a right answer that fits every situation. And we know that addressing such a complicated question in a brief talk with no opportunity for individual follow up might leave some of you feeling really unsatisfied. And we thought carefully about this, but decided to include this because it comes up so often in our conversations with parents. And we're really hoping that it will be helpful to hear about how open communication might sound, even about the hardest topics. So, to start, we know that parents are often looking for a balance. On the one hand, trying not to make unkeepable promises, and on the other hand, trying not to take away all hope for anyone. I think that many parents intuitively try to blend honesty and hope. This can sound different in different situations. And so initially, you might say something like this: "We know ALS will shorten my life, but we don't know by how much. Everybody is different. Doctors are working hard to try to find a cure." Or, "People do die from ALS, and there's not a cure for what I have, but there are things my doctors and I are trying to do to manage it. I hope to live as long as I can." Unfortunately, we can't promise that no one will ever die. And we also want to emphasize that we are not in the business of making unkeepable promises. But we can look for ways to create zones of safety that allow children to be a little bit less vigilant for some period of time. Even when that isn't really possible because time may be short, it can be a real gift to children when parents are willing to talk about it, and then they can actively support them as they begin to adjust to that possibility. So, with that window of safety in mind, you might say, "No one thinks I'll die this week or this month, but I am trying to prepare. Mom or I will let you know if it seems like I could die soon." Also note that this process often occurs much faster with teens and young adults. You're much more likely to share your diagnosis quickly and then have this discussion much sooner than you would with a younger child. Next slide. So now we want to talk a little bit more about kind of imminently preparing for the end of someone's life. So, as we said in the previous slide, we like to blend honesty and hope. At the very end of someone's life, we can give license to hope up until a certain point, but then it's going to be important to explain that someone's time will be short. With the other things, you can start by describing recent changes, like grandpa has been sleeping a lot, and invite your child's observations. You then can describe what the child might expect to see, what's still unknown, and when you might know more. You might say, "ALS is affecting dad's breathing a lot. I'm not sure he will live much longer." This allows children the opportunity to prepare and say goodbye. Children's questions might help guide the conversation, but not completely. Children avoid asking questions for a lot of reasons, often, let's say, to protect a family member, but we believe it's important that they have the information that they need to know. You'll also want to identify and address children's fears. Again, just like with other things, children's fears can often be concrete and egocentric. And so, at a minimum, you'll want to reassure them that they will always be loved and cared for. Next slide. Now, we want to talk a little bit about legacy, shifting a little bit away from communication. So, some parents will choose to prepare for their anticipated death by considering what legacy they want to leave for their family and by preparing mementos of love. These can be gifts that symbolize family history and values, like a family Bible, a collection of family recipes, a favorite tool, or a piece of jewelry that has special meaning. Some parents write letters to children. Children appreciate seeing themselves through a parent's eyes, knowing what makes them special to the parent, and being reminded of good memories. Parents might share general hopes for a child's future, but we caution that sharing specific expectations can cause distress for a child who may not meet those expectations in some way. Children also might like to know more about the parent as a person. What did they value? What made them proud? When there was a conflict between the parent and child, it can be very comforting for a child to have a letter that acknowledges how much the parent always loved them and that the parent trusted that despite the conflict, the child also loved them too. Also, note that we want legacies to feel manageable. We are more likely to encourage one letter rather than cards for every birthday for the next decade. Some people might also want to think about creating a living legacy, i.e., people or adults who have known that person at different points in their life, who would be available to their children in the future and could answer questions or share stories about the parent. Next slide. So, with all of that said, we want to now direct you to some resources that we have available on our website. You'll see the link at the bottom. I think it's probably easiest to Google the Mass General Hospital ALS PACT program, where you will find a series of handouts on our website. So you will find 14 handouts on parenting with ALS, covering up, a range of things, communication, bulbar symptoms, helping children adjust to changes in motor skills, etc. There's also a handout on the basics of ALS for mental health clinicians. If your child's therapist or your therapist would benefit from learning more, we often find that folks need some education. And then there's also a handout for multidisciplinary teams. These handouts are freely available for download in English and Spanish. Next slide. Just so you know what to look for, again, that is our website. On the right is what it looks like at the top of the page, Parenting at a Challenging Time, a little bit of information about our program. And then on the left side of the screen, if you scroll down the page, you will find where to download all of these handouts. And we will conclude with just some additional resources that we have found helpful and that we often recommend to families. There are websites. Our Cancer Center PACT program at Mass General has its own website, and it has a lot of information on child development, communication. It's very cancer focused, but it's certainly applicable to other illnesses. Books, Raising an Emotionally Healthy Child When a Parent is Sick is one that we often recommend. And then in terms of mental health supports, Cindy talked about those earlier. And that concludes our slides.
Wonderful, wonderful. Thank you both so much for that great presentation. We did have a couple questions that came across, so I'm going to jump right into them, and we'll try to get through as many as we can. The first one is it important for a younger child to feel helpful in regards to their parents' ALS care? And are there developmentally appropriate ways to address this? Specifically, the younger 2 to 5 range, maybe.
Mhm. So I would say you can certainly think about ways for younger children to be helpful. They're kind of developing a sense of empathy. And so I think maybe the most common example we think of is like a child getting something for a parent, like a glass of water. Um, so I think that that can be very helpful and important. And I think another kind of developmental piece for that age group too is being curious. And so, they might be interested in a parent's equipment, wheelchair. They might ask questions about this. So I think, yes, you can find simple ways for them to be helpful. The most common example I think of is fetching something and then also having them be curious, teaching them things, showing them things. Um, is my quick reply to that.
Thank you. Thank you. What is the appropriate approach for when a child or a teenager does not want to talk about his or her feelings, for one reason or another?
Mhm. Cindy, you want to take this
Sure.
one?
I think that comes up commonly. Lots of teenagers developmentally appropriate to share feelings with people other than parents. So it's worth thinking about whether this is a significant change from that child's baseline. Some parents will say, my kid has always been someone who's not really a big talker, or in the last few years, they're not a big talker. So if it's consistent over time, then we tend to worry less about it. If it's a significant change, then that's something we would pay more attention to. Think giving a child the option to talk without kind of pressuring, thinking about, ways, are you hearing too much or too little? Do you have people to talk to as you need? Are you telling your friends about this? And are they saying kind of stupid things in response? Or do your friends kind of seem to be supportive? Like trying to get a sense of whether there's anybody for the child to talk to, making sure that there's somebody if they wanted to. And then considering all of that against the backdrop of just how the child's functioning generally. Like, are you worried that they're depressed because of withdrawal, because of falling grades or something else? And that is then, of course, more of a concern than if the child is just kind of an internal processor and keeping things to themselves, but still doing the things that they typically have done.
Okay. Is there a certain age where it's the most appropriate to maybe start these conversations? Another way to phrase that maybe, is there ever an age where a child may be too young to start or have these types of conversations?
Yeah, good question. So I would say generally, we believe in having some sort of conversation with children, generally, depending on their language skills, as young as 3.
Okay.
So in the scripts, we talked about kind of the level of detail will be different across different ages, but children are observant. It's helpful to tell them something as young as the age of 3.
Okay, perfect. Um, I believe Dr. White, it was on one of your slides. You said to tell children, don't worry alone. Can you elaborate on what that means?
Yeah. So we hope that children will be open with their parents and caregivers about their questions, their worries, and their feelings. And so, to the other question, like not all children want to talk about them all of the time, but we hope that parents will communicate a message of please feel free to be open with us and to come to us.
Okay, wonderful. A couple more, and I know we're pretty much at time. Just one or two more here. At what point would you recommend maybe involving a child psychologist or a therapist? Are there certain signs or times when that would be most appropriate?
Cindy, you want to do that one?
Yeah, I mean, I think going back to that slide where we talked about red flags. So again, changes in mood or functioning that last more than a couple of weeks, that are more than just a few days after, a significant, conversation. Thinking about changes in functioning across more than one setting. So if they're grouchy at home, but fine with friends, fine at school, then, that has a lower kind of that's a lower concern than a child who's, across kind of many settings or many relationships seeming difficult, or seeming different. Again, any risky behavior, any talk of not wanting to live, self-harm, anything like that, those are definitely red signs. Child, saying they kind of need someone to talk to, needing some more support. Even kids who are saying, I don't need support, don't always understand what it's going to look like. So it can be helpful to sort of describe what it is you're thinking about, that this is sort of a coach to help you with kind of managing understandable, strong feelings. It's not that you're broken. It's not that anything is wrong with you. It's just, it's having a little bit of extra help in managing a stressful situation. Using words like I'm sensing that you're stressed, as opposed to I'm sensing that you're really sad or anxious, can sometimes feel a little more comfortable to kids, maybe especially boys.
Okay. And our final question before we wrap up, are there any specific age groups or developmental stages where children are more vulnerable to the stress of a parent's illness, maybe compared to some other age ranges?
Mm.
Hmm. Cindy, do you want to do that one again?
Yeah, that's a good question. I guess, to be honest, I don't know that there's any research about that.
Okay.
I think kids are kind of differently vulnerable at different ages. So, with younger kids, it has to do with sort of attachment security, in the sense that if a co-parent, say, is so involved necessarily in caring for the parent who's ill, and then the child doesn't have a sense to develop the feeling that their needs will be reliably, consistently met, that is a risk factor. And kids 0 to 3, brain architecture is developing, and so that's a really important age for consistent parenting and needs being met. And then beyond that, I think different ages have different kinds of risks. For a teenager, I think teenagers more than other ages tend to get, it's assumed that they can manage the care for a parent that maybe a younger child would not be given, and so they're at risk for kind of being overburdened. Sometimes there has to be good conversation and really support for the child, and managing care that may feel scary at times for them to provide. So I think it's just different risks at different ages.
Okay, perfect. And I appreciate those answers. And unfortunately, we are out of time. I do want to say that one of the resources you mentioned, Raising an Emotionally Healthy Child When a Parent is Sick, I have that book on my desk and I can attest it is excellent. It is a great resource and very informative. So, with that, I would once again just like to thank our wonderful speakers, Dr. Cindy Moore and Dr. Allison White, for the amazing presentation. Couple of quick reminders. You can view a recording of this webinar on our educational webinars page at als.org/webinars. You can also use the webpage to view all of the past webinars we have hosted, as well as sign up for upcoming webinars. Lastly, a final reminder that you will receive a short survey when we end this webinar. I just want to thank everyone who was in attendance today, and thank you again to our great speakers. We hope everyone has a good rest of your day. Thank you.